really, in essence, sort of setting the stage for our understanding about behavioral health data and care coordination, where this all sort of fits before we move into the panel discussion. Mike, if you could move to the next slide, please. So, again, the researcher in me giggles a little bit when I did this stuff. It's fun. Last month, when our focus was really on the longitudinal care plan, the longitudinal patient record, we asked the question, how would you rate the impact of these different players in shaping the culture of transparency in a medical encounter? To what extent does the patient have an impact, administrators of a healthcare organization, a clinic, or clinicians themselves? And we used, again, a 5-point scale here, 1 to 5, 1 being very poor, 5 being very good. So, feeling like I'm Richard Dawson, you know, the answer is, very interesting, is that there was 36 respondents. So from a statistical standpoint, you know, we can sort of nod and say, okay, not bad. But it is actually reflective of the audience that attends these roundtables. So I would argue that, you know, we're fairly skewed, segmented population. We're knowledgeable about healthcare and healthcare IT. So we're not going to be reflective of the market itself, but of this audience. It's very interesting. In essence, do not see that much of a difference between patients and clinicians in terms of who has sort of the impact. What the big takeaway for me on this is the role of administration has an impact, but certainly not seen as impactful as the others. Now, the other takeaway from this slide is we do not see one dominant over the other. They're fairly consistent in terms of the impact, but we do, again, sort of this variance, somewhat of the variance in the scores. Yet, the really interesting thing is diving into the next slide. When we sort of dive into the data itself, pull it apart, what does it say? Is there something here? And again, from my research this says to me a really fascinating thing is that of the patients, when we sort of look at who has the impact and we look at the patients, our respondents tend to show a degree of certainty around the impact. You really, for the most part, we saw a bifurcation of the audience here. Good percentage of the market of our respondents thought that the patient had a really impact. Although a third were certain that it didn't. It's that middle band that I find fascinating, is that very few of our respondents were straddling around the patient. It was either one way or the other. Yet, when we start turning our attention to the role of the administrators and clinicians, there seems to be an increase in ambiguity and uncertainty of the impact. All very fascinating, and so, as we go towards HIMSS, and we have a few goodies in line, these are the type of dialogue that I would love for us to be having while we were there. And we do have, at the end of today's presentation, another opportunity, another question that we will be presenting, and again, in a likewise fashion, we'd love to explore this data and the findings. So I have giggled enough. Mike, we can move to the next slide if you would. And I am actually going to turn it over to my colleague, Mari Greenberger. Mari, if you could sort of help us understand where behavioral health is sitting in HIMSS world, and we'll let you take it from there. Thank you, Mari.
Wonderful. Thank you so much, Lauren, and good afternoon, everyone. Thanks for joining us today. I have the distinct pleasure of introducing our moderator as well as our panelists today. As my role as Director of Informatics here at HIMSS North America, I get the luxury of working with our volunteers and members who work within health information exchanges, both the organization and the noun, as well as the verb, in addition to interoperability and standards. So definitely understand there is a need to have continue the conversation and engage in dialogue that very much incorporates behavioral health and the care coordination components that it touches from that perspective. So with that, I will introduce our moderator as well as our panelists. So starting with our moderator, Michael Lardieri. He is currently Assistant Vice President of Strategic Program Development at Northwell Health, which is the 14th largest health system in the nation. In this capacity, he oversees the use of technology and the integration of physical and behavioral health care, including health information exchange, patient portals, use of smartphone technologies, and telemedicine. Prior to Northwell, Mr. Lardieri was Vice President, Health Information Technology and Strategic Development at the National Council for Behavioral Health, or the National Council. He has over 30 years of healthcare experience in inpatient, outpatient, and managed care settings, and was behavioral health administrator for one of the largest FQHCs in the nation. So Marlo, thank you for serving as moderator today. And then moving on to our panelist, Marlo Greenberg. Marlo is the CEO of Foothold Technology. Marlo has worked with nonprofit organizations and local governments as a consultant and educator, and is keenly aware of the philosophical and change management issues that occur with the integration of new technology. He shapes many of the partnerships that help Foothold serve its client agencies. And moving on to Renee Popovits. Renee is the founder of Popovits Law Group and has been a practicing healthcare attorney for 27 years, representing behavioral health providers across the country, physician practice clients, research organizations, trade associations, and governmental entities in a variety of health law policy issues involving ethics, insurance, and parity issues, contracting, behavioral health integration projects, corporate compliance, confidentiality, HIPAA, licensure, reimbursement, data sharing, electronic records, and health information exchange. She's done a lot. Ms. Popovits has focused her career on legal issues impacting the substance use disorder treatment field, serving as general counsel to a number of providers. Thank you, Renee, for being here. And Tom Moore. Tom is currently the Vice President of Innovation for HealthX, a leading regional health information organization, or RIO, providing services in Metro New York City to millions of patients and thousands of providers from hospitals, physician practices, home health agencies, nursing homes, and managed care organizations. In addition to leading several major interoperability initiatives, Tom works closely with HealthX members to define and design information services to support improvements in care coordination across disparate organizations. Thanks, Tom, for being here. And last and certainly not least, Ioana Sigurano has 25 years of experience in software architecture and development and standard-based interoperability. For the past 20 years, she has helped develop standards for EHR technology to ensure that best industry practices are adopted consistently to accelerate the adoption of interoperable electronic health record systems and medical devices in healthcare. As a technical consultant, Ms. Sigurano has collaborated with leading healthcare organizations, vendors, and consortia to create standard implementation guides and analysis models intended to improve the exchange of substance abuse and mental health across the continuum of care using industry standards that are consistent with local and federal privacy policies. So with that, we clearly have some very experts on the line here. So I'm going to move ahead and ask Mike Kroll to go to the next slide, where I'm going to have, and apologies, go ahead to the next slide. Thanks, Mike. And this is where I'm going to hand it over to Michael, our moderator, who's going to set the stage a bit here, and then we'll jump right into our panel. So with that, Michael, take it away.
Thank you, Mari, and appreciate HIMSS having us here and everyone on the panel for participating today. And folks that are listening, if you want to, we'd like this to be interactive as much as possible, so feel free to send in a question as we move forward and have our discussion. And as you'll note, we have people who represent providers, technology, vendors, health information exchange, technology software developers, as well as legal representation. So I think we'll have a broad stroke approach to how we resolve some of these problems. As we move forward, we'll talk about not only what the issues are, we'll give a little the history of what some of the issues are and clarify some things, but also try to identify how we've been able to resolve some of the barriers as we move forward. So the first slide here, what we're going to talk about a little bit is, so why are we even talking about the behavioral health, and what does it matter? Well, it matters because at any one point in time, almost 25% of your population, let's say 20%, more than 20%, a fifth of the population has a behavioral health disorder. So that's a huge percentage of the population, and as we move towards integrated care and quality payments and MACRA and MIPS and all of those things, if we don't integrate care across the spectrum for a particular patient, we're really not going to be able to provide them good quality care. And if we don't provide them good quality care, we're really not going to be able to provide them cost-effective care. Next slide. So there's also a life expectancy issue. So we do know from research that people with behavioral health disorders, they die earlier than people who have no behavioral health disorder. It's a disparities issue if you look at it that way, and we do, many of us in the behavioral health field, and the people that we're talking about that are dying earlier with a behavioral health disorder, they're not dying earlier from a behavioral health disorder. They're really dying earlier from a chronic medical disease that's going untreated. So there is really a need to integrate behavioral health treatment with medical treatment so that these patients can get the appropriate treatment, the same as anyone else in the country that may just have a medical disorder and no mental disorder. Next slide. So there's also a cost issue. So this slide identifies the cost of care for people who have no mental disorder versus those who have a mental disorder. And you can see that across the private sector, where we're talking Medicare or we're talking Medicaid, the costs are significantly higher for patients who have an untreated behavioral health disorder versus folks who have no behavioral health disorder. So if we're looking to turn around the economy and provide better cost of care, patient experience, we really need to address these issues across all payer realms. Next slide. This is a slide specific to New York State that really, again, drives home the costs of the program. And this is a Medicaid program only with these statistics, but the cost to Medicaid in New York State is significantly higher when a person has a mental health disorder or a substance use disorder. And you can see that when they have no mental health or substance use disorder with the physical health care costs, those are significantly lower for a patient. So if we begin to integrate care, share information, we may not be saving so much on the behavioral health costs, because oftentimes we're actually going to see we're going to be increasing behavioral health costs a little bit, more outpatient treatment, that type of thing. But where it'll have an effect is on lower medical costs. So the overall and the total cost of the patient comes out to be less. So that's really where integration comes in. It's not you're saving just for behavioral health. You're really saving in the total cost of care for the patient. Next slide. So now we'll actually, I have a couple of questions that I want to start with. Before I do that, just want to remind folks that Thursday, on the 17th, the Surgeon General, it's very timely with this discussion, but the Surgeon General is going to put out their report on opiate and drug abuse that they've been preparing. One thing that we do know is that there's an opiate overdose death every 19 minutes. So during the course of this hour, 3 people will die from an opiate overdose. Now, how much of that are street drugs versus prescription medications? I couldn't tell you that right now, but we know we do have a prescription medication problem in the country. And again, that points to really coordinating care and the need to coordinate care and share information between behavioral health and medical. And then there are about 27 million people who misuse alcohol or drugs each year. So I'm going to start off with a question to the panelists, and really just to start with, what are the barriers, both real and perceived, to sharing behavioral health data? Why don't we start there and talk about what's real and what's perceived out there in terms of the problems with sharing behavioral health data. And I'll leave that to anybody to jump in.
This is Marlo. I guess I'll jump in.
Okay.
We, just for a little bit of background and context, Foothold works exclusively or almost exclusively with private nonprofit organizations that provide behavioral health services. So these are not hospitals, they're not generally state governments or county governments. These are standalone private nonprofit organizations, generally community-based. And we see, I think, 3 kinds of barriers for our clients as they look to whether and to what degree they can share data with health information exchanges. Primarily, one of the first barriers that pops up is related to money and where they're going to find the resources, both in terms of dollars to pay for the actual exchange of data, even though it's not particularly expensive, but also in terms of internal resources about making decisions regarding who is able to exchange data, who is going to be able to, sort of direct and understand what the data that they're bringing in and sending out means, and who's receiving it, and sort of just managing the exchange. The other issue is that, a lot of these organizations started way back in the 80s when Reagan privatized a lot of these services, and they have a cultural stance of advocacy, and they really don't love the idea of sending what they view to be private personal data anywhere else. They're used to a world where a lot of these behavioral health issues have been highly stigmatized and are, sort of thought to push people out of the mainstream, and so they really work pretty hard to protect the folks that they're assisting from that kind of exposure. And so there's just even if you can convince them of the kind of the technical safety of the data that they're sharing, they simply don't like the idea of moving that data around from organization to organization. But the last piece, and I think the biggest barrier for behavioral health organizations, at least my sort of standalone private nonprofit organizations, is motivation. Why are they doing this? What are they going to get out of sharing this data with other organizations? How are we going to take the data that comes from other organizations and integrate it into their workflow in a way that actually has a positive impact on the care that they're providing? And I think the motivation issue is in some ways most easily addressed, but it's also the most diffuse in some ways. It's a little bit hard to understand who needs to be convinced of what, and also what the real answers are, because they differ from organization to organization depending on how they're organized and the kinds of services they provide and like that. So I would say, money, motivation, and sort of an advocacy stance on privacy and confidentiality are the 3 main barriers.
Mm-hmm. Great. Thanks, Marlo. Other panelists have a input on this?
This is Tom Moore from HealthX. I'll give the perspective from the HIE, and HealthX is a regulated HIE. We're private, not for profit, but we're heavily regulated by the state and certified to perform this function. One of the things we have to do is comply with a lot of regulations, and one of the ones that's toughest for us to meet are the SAMHSA regulations. And just to give you an idea, a lot of the organizations, sister organizations of like ours in other parts of the state, do not have behavioral health data in the HIE because they can't deal with the SAMHSA regulations. We've come up with some good approaches for it. It's not easy, but we comply with SAMHSA by providing non-redisclosure notices whenever SAMHSA data is present. We have special rules around consent that are barriers to what we can provide, but it respects the SAMHSA rules. And I think that's a good balance because it meets the privacy concerns that Marlo is alluding to that our participants have, but through this technical, by overcoming these technical barriers, we're able to let the data flow with respect to the patient's privacy, but get the data to the people who still need it to provide their care.
Mm-hmm.
And this is Ioana Singorano. I just wanted to add to the issue of trust, which I think both Marlo and Tom alluded to, and that is, what is the trust of patients, what is the trust that providers have that information is shared in a way that is secure, that conforms with privacy policies and other security policies that may be applicable to an organization. So one of the areas that I've been active in is to create standards that simplifies the exchange of information by adding simple metadata annotations to the information. So ONC has been looking at the issue of provenance, for example, tracking the data to its source. They also have been looking at the issue of data segmentation and sharing metadata, such as, the obligation to not redisclose data without consent. And basically, what we've seen from pilot projects is by reducing the complexity of the policy to a set of technical criteria that could be easily evaluated, then we can have HIEs that can combine behavioral health and medical health records in one place, as long as the metadata distinguishes the two types of information. So that basically allows the information to be commingled, but to be clearly delineated and segmented accordingly. So I think from my point of view, going to the issue of trust and cost, one opportunity we have in this area is to establish standards and software tools and software components that can lower the cost of implementing a secure, privacy-aware solutions. And that's what I've seen coming out of these projects. A few well-defined metadata elements that can tell you that information is restricted and it has to be redisclosed under certain conditions, can make systems much more interoperable, and also allows this information to be integrated in the continuum of care. Now, as far as incentives and what is the motivation for an organization to sign up to an exchange and share information with primary care physicians, I think that's something that we will still have to see in the coming years, and how new reimbursement models may be able to address this. But I think the trust issue, both from the point of view of the patient who may indeed have a stigmatizing condition, and from the point of view of the provider who wants to act in the best interest of the patient, and also from the point of view of the HIE, which wishes to act in a way that is consistent with the policy, but without the added burden of trying to understand the variety of jurisdictional policies that may apply in each institution. I think there is an opportunity there to leverage standards to help us bridge those gaps, and also to allow us to operate in an environment that is really a mosaic of policies. So we need to have systems that are sufficiently flexible that they can accommodate the evolving policies.
That's great, Juana. And I know you've been working on this for a long time. So, I'm not sure the different level of participants on the webinar, but to try to rephrase or clarify what you're identifying. By identifying these standards in the metadata, that will allow an organization to accept the data, and then if they were going to send it to an organization such as Tom's via a vendor such as Marlo and Foothold Technology, that having that metadata would allow Foothold to restrict, say, the substance use data from going to the HIE, depending on the patient's preference and that policy for that particular patient?
Precisely. I mean, for instance, if you're a source organization, you can establish certain policies. So, for example, there may be default policies in your organization, but there may be also federal and state policies that apply to the data. So, when you send information out of your organization, you can make sure that the information is annotated to say this information was shared because there was consent to share it, but you cannot redisclose it without asking for this consent again. So that may be a level of processing that's already happened on the source system. The receiving system knows now that if they wish to share it with someone, that institution, that organization has to produce a consent. So let's say Marlo's client publish information on an HIE with all the annotations required. Now, another organization may request this information and supply a consent. In that case, the HIE could share that information if the consent matches and it meets the necessary metadata requirements. So now we can have two organizations that basically don't know each other working through a trusted partner that enforces these policies both as a receiver of information and as a sender of information. So we can actually have solutions that don't require, sender A and receiver B to know each other, but they each have a trust relationship with the HIE.
Great. Yeah, they're very good. Thanks for that explanation. And then we'll probably come back to this later on. But we do get to the issue of consent. And with that, I'd want to toss a question out to Renee. And Renee, I see you're on mute, so you're going to need to unmute yourself. So the question I have is, what are the issues that need to be addressed in a consent form to exchange behavioral health data, comply with state and federal laws, specifically 42 CFR Part 2, which is the federal regulation for substance use, which seems to get in the way more than mental health, but some states' mental health is an issue too, to ensure that patients understand what data will be shared. So I wonder if you could talk about that a little bit.
Sure. Thanks, Mike. Can you hear me okay now?
Yeah, you're good.
Okay, good. In terms of the 42 CFR Part 2 consent, that consent governs confidentiality of drug and alcohol treatment records. And I think the first thing that's really important for folks to understand on this call is that the addiction treatment information itself is not protected under the confidentiality laws, only records that are held by a federally assisted program. So if there is information shared in a hospital or that doesn't have a designated unit, or in an emergency room, or in a federally qualified health center that doesn't have a specific behavioral health specialist, or in a physician office, even though it's drug or alcohol treatment information, it doesn't have the special protections. It would be governed by HIPAA, and the information could be shared for treatment, payment, or healthcare operations. So I think that that's really important to understand first and foremost, because I think that that's a common myth that is misunderstood. And if it is information that's coming from a Part 2 program, so it's federally assisted and it meets the definition of a program, then there's a very specific consent form that is required that has a number of elements. A lot of those elements mirror the elements of an authorization under HIPAA, but there's a few specific requirements that seem to be getting in the way of health information exchange. And that primary issue is the to whom section. The to whom is when you have a consent form and say Tom's program wants to release something to the HIE and to other providers involved in their care. SAMHSA has taken a position that the to whom has to be very specific. They have since issued some proposed regulations in February of this year, February 9th of this year, and the comment period closed on April 11th, that would relax some of those requirements. So I think we need to be watching out for the final regulations that will be issued under 42 CFR Part 2. But in the meantime, I think that there are a couple of things that providers and health information exchanges can look at in order to share the information. The first idea would be to look at how you're defining health information exchange. SAMHSA has issued some FAQs, and there appears to be a little bit of wiggle room in there of what constitutes the health information exchange and how information can be shared among participants within the exchange. There's also another option of a qualified service organization agreement that can be used in connection with consent. And I think the other thing that is really important, especially in light of the opioid crisis, and as Mike mentioned, the Surgeon General is releasing his report on Thursday, is that there's another section in 42 CFR Part 2 that we really haven't focused in on, and this may be new to some of you. There's a section that deals with central registries. And a central registry is an organization which obtains information from 2 or more member programs that has patient identifying information that where they're getting information about people applying for withdrawal management or maintenance treatment for the purpose of avoiding an individual's concurrent enrollment in more than one treatment program. And so when you look at those consent requirements, and we know that treatment is being expanded under CARA as well as under other portions of state and federal statutes where physicians are prescribing buprenorphine, FQHCs are doing more things. So I think that that consent section should be looked at, and the reason for that is it allows, in that consent form, you to list the name and address of each central registry and each known withdrawal management or maintenance treatment program to which a disclosure is made. And if you don't know it, the consent can also authorize a disclosure to any withdrawal management or maintenance treatment program established within 200 miles of the program after the consent is given without naming any such program. So right within SAMHSA's own regulations, even though they've been giving us pushback on the to whom as we've been trying to deal with HIEs and accountable care organizations, there already exists an exception to allow a general designation for persons who may need opioid treatment. So you should take a close look at that. And then finally, I do want to raise the issue because I think that this is another myth. There is a real enforcement problem with 42 CFR Part 2. I know that a lot of people have been pretty conservative about it because they want to do the right thing. They want to follow the law. But the statute has a drafting error in it, and if you want to look at more information about that, there's a paper that we wrote on it for the American Behavioral Health Wellness Association, and I can share more of that information with folks offline.
Great, thank you. And a question did come in around HIV and SMI data, seriously mentally ill. I'm assuming that's what the questioner asked with SMI. So from the discussion so far, it would seem that if a program is an HIV program and they also treat substance use, then it's really not the 42 CFR Part 2 regulations that would take effect, but the regulations of HIV in that particular state would be in effect, and the organization would need to get the appropriate consent for HIV. Is that the way that your clients, Marlo, and then Tom, as you're processing the information from Marlo's clients to others, is that the way you folks are managing the HIV data, if it happens to have substance use data in it as well, or mental health data in it as well?
Yes. Sorry. You want to go first,
Marlo? Yeah, go ahead.
Yes, that's how we're doing it, although there's more segmentation in our data originally at origination than that suggests, right? So really our clients are, and again, this just sort of goes back to my original points about some of the barriers to starting this, which is that to the degree that there are challenges at the organization around workflow and who's going to manage this and what data they're sharing and why and what they're going to do with incoming and what kind of outgoing they're sharing, the data exporting is generally focused on a single program. So most of my clients are still divided by the programmatic funding streams that they're using to provide these services in the first place. So you don't often get in our environment yet, although I do hope that it will change one day, because I think it's a sign of maturity for it to be a lot of data from a lot of different programs and services. But we don't often get today more than one set of data from one particular program. So there's not really a challenge around splitting up the different kinds of data. There are issues around folks who are receiving a particular kind of mental health service and also happen to be in a domestic violence shelter, for example, and how knowledge of their participation in the domestic violence program or shelter can be kept out of whatever other data we're sharing with them. But we don't have a mix right now between mental health and HIV.
Okay. And then Tom, you were going to chime in?
Yeah. So one of the things that HealthFix has always been clear that we can't do, and this was discussed earlier, is separate the data by whether or not it contains something that indicates that the patient has, say, HIV or substance abuse and mental health issues. So it's clearly stated on the consent form that any and all data that's put into HealthFix is available if they consent to it. However, in the case of a 42 CFR Part 2 organization, we register all of those that contribute data to HealthFix. And if any data comes from any of those facilities, again, we don't know what's necessarily in that data that's coming in, but if it comes from any of those facilities, then anyone who queries that data receives a non-redisclosure notice that they're forbidden from redisclosing that information. And as I mentioned earlier, there are other barriers to our ability to exchange data coming from these types of facilities. So again, there are clear ways on the surface of saying this patient has HIV, such as certain lab tests, medications, and diagnoses clearly indicate that, but we can't be certain that other things, other lab tests, other medications that aren't obviously or uniquely for the purpose of, say, HIV treatment aren't going to give some indication that the patient has HIV. So we don't want to try to profess that we can filter out any of that data.
And just wanted to add something to that. So typically the responsibility for segmentation relies on, lives with the organization that is the source of the information. So if the HIV information is deemed to be, so HIV is not universally I recognize as being confidential information. In some states and jurisdictions it is, and some others it's not. But if the issue arises when one organization exchanges information with another organization with different policies. So in this case, I think, again, from a standard standpoint, we want to use the same kind of annotations to represent that information is confidential, regardless of why it is confidential. And the source system knows why it's confidential. It's supposed to comply with a certain policy. So let's say we have a mix of HIV and mental health information that is deemed to be confidential in a state. If that information is exchanged with an entity in another state, the entity the receiving entity will know that this information is confidential. They may not recognize it as confidential based on their own criteria, but because the source designated it as such, there is a responsibility on the side on the receiver of that information to meet the confidentiality requirements that are attached to the data. So this way, I think that the appeal of this sort of technical approach, if I may, is to say, if we have a clear assignment of responsibility to who is supposed to annotate the data, then we have a correct assignment of policy implications based on that information at the source where it's applicable, where it matters. And then the receiving systems, in terms of an ecosystem around an HIE or some other sort of exchange, have to all recognize the metadata and the information that describes to you what are your obligations when you get that information, whether you're under an obligation to reconsent this information upon redisclosure, or if you have to protect it in some other way once it arrives in your organization. So in some cases, the policy is straightforward. 42 CFR Part 2 covered entity, that means the whole record is not to be redisclosed. But in other cases, it may be more difficult because other policies may overlay on top of 42 CFR Part 2, having to do with mental health abuse, mental health, HIV, domestic abuse. So different states have different other policies that deem information to be confidential.
I agree. I think the state laws are the ones that are going to dictate for both HIV information and mental health information. What I think is important to consider from a provider standpoint is, does the technology, the metadata that you're discussing, does it have the ability to match up with the granularity of a consent form? Because it's one thing to kind of tag the data, but it's another thing to have the consent form be able to understand what data is being tagged and who has authorization to release it. So in some healthcare systems that are truly seeking to better coordinate care and better manage population health, they're starting to develop consent forms that are very straightforward. That's basically saying, we are sharing all your information with all of our providers involved in your care, so that way the patients understand it. If you don't want that information shared, then you need to opt out or let us know about that. And then we're also including an express provision that allows for redisclosure, because 42 CFR Part 2 in the consent requirements doesn't have an element that says this is you have to have the prohibition on redisclosure. There's a separate section that says you have to notify people about the prohibition on redisclosure, and it doesn't specifically tell you how can a client consent to redisclosure. It's pretty much left open. And what's interesting about that is when we look at when that provision was originally added to those regulations in 1987, in the preamble, which is the language to a rule that kind of explains a government agency's rationale behind something, that preamble actually it gave an example. They gave this example. The final rule rewords the statement of prohibition on redisclosure and adds the phrase, unless further disclosure is expressly permitted by the written consent of the person to whom it pertains. The purpose of this added phrase is to acknowledge that redisclosure of information may be expressly permitted in the patient's written consent. For example, and this is exactly what the rule says, a patient may consent to disclose pertinent information to an employment agency and at the same time permit the employment agency to redisclose this information to potential employers, thus making it unnecessary for additional consent forms for redisclosure to individual employers. Similarly, and then it goes on to give some other examples, but I think that is a great example of how healthcare organizations can include in their consent forms and express redisclosure provisions that says we're going to share this with providers involved in your care. We're going to redisclose it. So you have a valid consent that has the specific to whom, but we're going to redisclose it. It's worth considering that, and then if you add that to your consent form, you may want to add the language that we saw in the proposed rule that says basically if we disclose to people under a general designation, you have the right to ask for an accounting of who we have disclosed it to. I think what's most important is that the focus should always be on the patient, and if you're honest with the patient and you're telling them what you're doing with it, there's less likelihood that you would have legal concerns and, more importantly, patient care concerns.
Right. Yeah, and that's a good point, that last one, Renee, and it has to do, from the provider side, it has to do with, having explained the consent and having informed consent from the patient. Oftentimes, and Part 2 has been around for a long time. It's a little vague in many areas. It seems that over the years, people have gravitated to one interpretation, but there are these other components of it that sort of have been put on the side. But I found as a provider, if I explain to the patient what they should expect to happen and the benefits. So there are benefits to sharing your information. If you're not in substance use or mental health, most other patients, if you have a very serious disease, many studies have found that those are the patients who want to share their information because they know they'll get better care. So that whole area of taking the time to explain consent is very important, because then it gets to what Ioana was speaking about at the source document, allowing the information to flow if the patient knows what's going to happen with it.
Exactly. And I just want to add to that you basically, the consent, it allows for information to be shared or identifies the information that cannot be shared. I mean, the policy identifies the information that it cannot be shared typically, and the consent is an affirmative statement from the patient saying, yes, I do agree. There's only one policy I know of where the default is opt-in and you have to opt out. But just wanted to add to the issue about redisclosure. I think more information about the ability to, for instance, disclose the information to the HIE and give the HIE permission to redisclose the information to specific providers in one fell swoop, which is what some HIEs are doing, is probably a more patient-friendly way of expressing consent. And also, the consent has to be expressed in a way in which the patient understands it, and it has to be processed by systems in a way that machines understand it. So, from a complexity standpoint, that's where the issue sometimes arises. But again, this is part of the work of standards development organizations to find ways in which we can define some objective way in which we can segment the data based on the clinical content of that information sometimes, and also just, use a set of, best practices and, segmentation rules that can be applied universally. What we don't want is every single organization having to reinterpret the policy, reinvent the solution, and try to implement it. Instead, we'd rather have the standards be the technical embodiment of the policy that everyone can implement consistently, if that makes sense.
Yes. I think it does, and we'll have to hear back from folks who are on the call to make sure they do. But I think it makes perfect sense to look at it that way. I'm going to switch a little bit based on a question that came in. So the question is, referencing the opiate overdose epidemic that we talked about earlier, do any of the panelists see a potential in EHR data and care coordination helping to reduce overdose risk of both street and prescribed drugs? And what are the obstacles or solutions around that?
This is Renee. I think that there's a couple of options for helping coordinate that data. One of them is the central registry, where you don't want people enrolling in, for example, multiple methadone programs where they would be seeking to get high as opposed to using it as a medicated-assisted form of treatment to be able to function without detoxing. I think the second area is the prescription data monitoring programs. I think that is key, because we're not just seeing opioid overdoses through illegal use of heroin and other street drugs. There are a lot of overdoses that are occurring with prescription drugs, and I think that that's an area that we need some further guidance on. When SAMHSA had issued some questions to address in their listening session back in June of 2014. They focused in on 7 areas, and one of the areas was prescription monitoring programs, yet when they came out with the proposed rule in February, they chose not to address it. I think it needs to be addressed. I think we need a uniform standard across the country, not individual standards by each state, because, you know, people cross state lines, and I think that that is an area that hopefully the new administration will be looking at. If they're looking at insurance across state lines, perhaps they'll be looking at PDMPs and other things across state lines.
You know, one of the sort of newer ideas that's happening here and there around the country in the Northwest, a little bit here in New York, is this idea of, you know, we're here talking about how to integrate behavioral health data into primary medical care data. There are some programs out there that are seeking to include law enforcement data in that bucket as well. And what happens when you do that, if you can find a way of exchanging all these different data sets and giving these different organizations access to these sort of broader data sets, is you start to be able to do things like have a crisis intervention program, so that rather than simply arresting someone for participation in an illegal market or illegal behavior based on their, you know, consumption of some substance, you actually bring them to a crisis intervention program, and then they become part of a sort of larger network of organizations that are designed to bring them back from wherever they were headed in the first place. We're having, I think it's safe to say, a tough enough time bringing behavioral and physical health data together to start worrying about police departments, but there is something really compelling about those sort of 3 legs of the stool, the physical health, the behavioral health, and the law enforcement data working together to provide care providers with a much better picture of particular individuals as they become engaged in, whether it's illicit or licit drug markets, and trying to stop some of these habits before they become ingrained and lead to disaster for people. And that sort of feeds into another development that's been going on for a while, but is sort of gaining strength and energy with the availability of data over the last few years, which is trying to figure out whether we can actually do something robust in terms of predictive analytics. In other words, is it possible to take demographic information, diagnostic information, and put that all together into a framework that can actually tell you, look, this person is headed for trouble. Based on everything we know about people with similar characteristics, this person is an opioid abuser waiting to happen. Now, there's not something sort of ironclad about any of the algorithms and any of the analytics that are out there, but people are really working at a pretty high level now with reams of data to try and provide some kind of predictive analytical engine that will help us figure out who's actually likely to get in trouble and who's not, so that we can better allocate resources.
Right.
If I may add to that, the issue of matching opioid treatment-seeking patients with the facilities that can meet their needs is also a challenge, because the opioid abuse epidemic happens in rural settings, and they're typically underserved in that regard. So a lot of, you know, what I see from a standards implementation standpoint, and an attempt to try to coordinate the resources of an area to match patients with providers who can help them, and also to see that we don't have either unused capacity or unmet needs. So I think we see people trying to be more efficient with the resources at hand.
Great. And there is a question that came up about, you know, whether the privacy laws and policies are so restrictive that, you know, family members are left out of the crisis and treatment plans. And I think that is part of the situation today. Especially if someone takes a strict interpretation of Part 2. If you're a family member and you call that outpatient substance use program, if the patient hasn't explicitly said, yes, share your information, or if it's an inpatient unit and the patient has not said, yes, please share my information with my family member, then more often than not, it's not shared, and then you know, you miss a very valuable resource in the patient's treatment, is their family. And, you know, being a clinician, some families are good for treatment, and there are some families that are not. But most families, if they do want to help their family member, it's good to have your family involved and work with the clinical staff if there are issues with the family that are instigating more crisis and hospitalizations. Then it's important for the family to be involved even more so. So that's an issue that's out there as well.
One of the things this is Tom, I just want to mention on the information side, there's a program in New York called iStop, which is for tracking the use of prescribed controlled substances. And it's a service that is, I think, required to be consulted by prescribers. And it's specifically for the purpose of informing physicians if they're maybe over-prescribing or prescribing for the wrong reasons. And this service we're in the process of integrating this service into the HealthX portal so that people who are looking at a community record on a patient with all their clinical data can also pop over to iStop and get information that they might not have from HealthX about controlled substances.
It is a requirement as part of the EPCS legislation, as far as I know, yeah.
Great. And we're coming up to the top of the hour, but I want to ask one more question and ask folks to be brief. But due to the diversity of electronic health records and the need for accurate and meaningful data, what do you recommend that healthcare providers do to be better prepared in order to share information and comply? And maybe we'll start and go around. Start with Marlo. Take maybe 10 seconds.
10 seconds. Oh my goodness!
Yeah, I know,
Mike,
it's a tough one.
That's a doctoral dissertation. Unfortunately, because it doesn't look like the new administration is headed in this direction. And I hate to say this as someone who appreciates the diversity of the marketplace, but the more standardization, the better. The SAMHSA idea for a national consent engine was insane because nothing like that's ever worked in our cultural and political environment before. But it's the right idea, which is we need some pretty strict rules of the road. We need to know what the data should look like, what structure it should be in. There shouldn't be that many options, and that will enable EHR developers, such as my company, to structure their data and the exchange of that data in a way that's going to be easy for other systems to digest it and for us to digest data from other systems as well. So the more of that, the better.
Great. And then looks like we're out. So I'm not going to be able to ask that from Tom and Juana and Renee. But I would want to thank you all for participating. This is a panel that can go on for many, many sessions. So unfortunately, we weren't able to get to everything today. But thank you very much, and we appreciate HIMSS inviting us all to participate. So with that, I guess I turn it back over to Lauren.
Yeah, Michael, thank you. Hey, everyone, thank you so much. This is great. I learned a lot. And again, as you said, we could go on and on. As we had said, we have questions that we do like to ask as you exit. And our question this time is, how confident are you in the healthcare community's ability to securely share health behavioral data? And Mike, just one last thing. We always do like to just remind folks that our next presentation is in December 13th at 2 p.m. Central, and our focus is going to be on care coordination and analytics. A very interesting topic as we'll be looking at the clinical business intelligence and some of the work that some of our folks that will actually be presenting at conference will be doing. So thank you to all, and hope you all have a great afternoon.